Community Health Center, Southeast Kansas. It's about an hour and 45 minutes straight south of here. This is our main clinic. We have 4, soon to be 5 clinics located in Southeast Kansas. This is the main clinic we had where we integrate behavioral health, dental, medical. We have a pharmacy. We have an attorney on staff. We have all kinds of stuff. So we're trying to physically and programmatically bridge that gap. So when you walk into this clinic, you could get about 15 different things at one time. And the purpose of that clearly is that we believe in holistic health care and that we're all one body system. But also when you put providers in that situation, when you let them practice and let them eat lunch with a dentist and they're an internist and a pediatrician talks to a psychiatrist and all that stuff happens, you can just sit back and watch integration happen. The other day I was doing a tour. We do it a lot because not very many people do what we do in this way. And I was walking through and I was talking about integrating oral health and medical care. Our dental clinic in this facility is right outside of our pediatric care clinic. And as soon as I say that, talking to people with money, because I like doing that, and as soon as I say that, a hygienist, like she's on cue, comes out and talks to one of our pediatric nurses about doing fluoride varnishes on Candy Healthies and well child checks. How many do you have? When do I do them? When do I get in? And I'm like, wow, that was cool. Like, push a button and here comes somebody else. Then I talked about how we bridge behavioral health and medical, because about 50% of our patients are either anxious or depressed when they come to see us. And so we had a kid with behavior problems, and we have a staff member who's a master's level social worker who goes in on all of our well child checks and does developmental ages and stages, developmental screens. The kid's having behavioral problems. Here she comes out of nowhere and starts talking to mom about the kid's behavior. And I was like, wow, you know, that was cool. So if you just put people in the same place together, they'll do it. Even without programs to encourage the behavior, they will do it if they're in the right place and they're the right kind of people. So this is where we do that. Community health centers, I want to talk. I'm sure you've heard some about them. They are called federally qualified health centers. I don't like that. That's a reimbursement mechanism term. They're community health centers. That's what they are. They are private or public nonprofit organizations. We are a private nonprofit organization. About 25% of our money comes from public sources. The rest of it, as I like to put it, we have to kill what we eat. So we have to provide billable services to patients that are billable, and the other patients we have to figure out a way to pay for. So they're not governmental entities at all. They're not coming in. They're not placed in locations by some entity out there. It's a highly competitive process. They're need-based. Clearly, the application is one of the most difficult things you can imagine. But it is but completely need-based, so it's competitive in that way. So if you have bad health outcomes, high health disparities, lots of poverty, you look really good on these applications. They're outcome-focused. That means when we started our clinic, we had less than 50% of our kids in Southeast Kansas were being immunized by the time they were 2. So we had to do something about it. We have to continually talk about what the problems are that we face, and we have to do something about it. So it's smart. It's smart healthcare. Our board of directors, that has to be at least 51% patients, consumers of the service. Community health centers were started in 1965 during the war on poverty. And the other 2 things that came out of that Office of Economic Opportunity that are still with us are Head Start and legal services. And the things they share in common is that you ask people what they want and you give it to them. You don't walk into a community and say, hey, we're going to do OB care if you don't need it. You ask them what they want. So they set our hours, they hire and fire my boss, they run the place. So we like to say we're patient-owned and operated. We provide care to everyone regardless of the ability to pay. So if they're low income and uninsured, we have a sliding scale. It can go all the way down to $10, and that includes all your lab, all your x-ray, all of that. Dental is $35 because it's a lot more expensive. Mental health is $25. And that gets back to the comprehensive integrated model. Enabling services, not a very pleasant word, but that's what we call it in the jargon. Those are all the wraparound services that we provide that help people get what they need. The difference between us and private providers of healthcare is that we look at our patient population and respond directly to what they need. So they need transportation, we get it for them. We have an attorney in our building because the legal problems that can cause bad health outcomes are incredible. In Pittsburgh, 50% of the housing where I live is rental housing. Part of that's because there's a small university there. Part of it's because we're incredibly poor. So what happens is you don't have lead assessments all the time. When you buy a house, you know you do your lead disclosure, not when you rent. So we have lots of kids with lead problems. And so we can address that with an attorney. We can do landlord-tenant kind of stuff. There are 13 community health centers in Kansas, and there are about 1,400 in the country. And get ready, because there's a lot more coming. There's $11 billion in healthcare reform for community health centers. So if you don't know your community health centers in your community or don't have one, there will be one, and the ones that are there are going to grow incredibly. It's going to be a real challenge because we have some infrastructure issues to deal with. This is what we do in our medical clinic. We do obstetrics. We deliver about 150 babies at the hospital. We have obstetricians. We do family practice. We have internal medicine. So we have the whole life cycle covered in our medical clinic. In our dental care, dental clinic, we do primary dental care, but it includes specialty stuff, oral surgery, all that kind of stuff, dentures, and a huge outreach program that I'll tell you a little bit more later. Behavioral health, we have psychologists and a psychiatrist. The thing that's important to know as I go through this is our goal is to provide the services our community needs, not just for poor people, quote unquote, but for everybody. So we have one of the few psychiatrists in Southeast Kansas works for us. We have obstetrician, we have family practice with OB doctors who are providers of choice in our community because people like them and they want to work with them. They're younger, they're female. We have 2 of the 4 pediatricians in our region, and they're younger and female, and some people are just more comfortable with that. So our goal is not just to provide care for one population, but for everybody who needs it. So think broadly, because when we take care of our community, we take care of everybody. When we say, regardless of ability to pay, that means that you can walk in with money and insurance, we love you. That's good. That's good for us, and we'll take care of you. And we have a lot of people who use us because they believe we're the best in the area, and they're right. We have a pharmacy that has a 340B drug program. That's something you guys might want to learn about if you don't know about it already. That's a federal program that provides drugs to community health centers and DISH, disproportionate share hospitals, hospitals that take care of more Medicare and Medicaid than other folks. And the drugs are as cheap as they can be had anywhere in the country. So we're cheaper than Walmart. You know, we're cheaper than everybody, especially on the expensive stuff. We had somebody come to us who was spending $500 a month on drugs. It's $62 with us a month, which also gives you an insight into how much money is being made in the drug industry, and it's disgusting. We are the Kansas Drug Repository. There's this innovative thing in Kansas where we take drugs that aren't being used, especially from large distributors, like they mail them to you, and you write, I don't want this, and UPS sends it back. In a lot of states, those drugs are then destroyed. In Kansas, they come to us and we give them to people. So we manage that. We also do a thing called the Manufacturer's Indigent Drug Program, which a lot of drug manufacturers have free programs that they like to be real proud of. And that's okay that they're proud of it, but they make it really complicated for people to use it. So at the same time, they're patting themselves on the back. They make it difficult by changing forms and making it hard to read. So we help people with that, and then the enabling services that I mentioned. This is our growth. We've been around since about 1997. We started as an outreach of a child care facility whose goal was to help kids be ready to learn. But they couldn't stay in school because they didn't have physicals and immunizations. So they started a medical program, and that grew. In 2003, we were first funded. 2003, we had 3,000 patients and 6,000 visits. Last year, we had 23,000 patients and 72,000 visits. And keep in mind, there's 175,000 people in the entire region. There are 20,000 people in the town that I live in. So we take care of a lot of people. These are our demographics. Way overrepresented with kids because when we started, we had problems with child health. We have one community in our service area that I'll talk more about in a minute, that 38% of the kids live below 100% of poverty. You guys know what that is. It's incredibly poor. So 50% of that 23,000 are children. So they're about double, they're about overrepresented by twice because we focus so much on going after kids. 56% female. Residents is primarily the 9 counties of Southeast Kansas, but last year we took care of people from 32 counties of Kansas. There's 105. Some of it was just 1 or 2 here and there, but primarily 9 counties. 3 counties in Missouri. We're about 6 miles from Missouri, and 1 county in Oklahoma, which will go up as we expand because we're building a clinic right on the Oklahoma border. Income, 72% are under 120% of poverty. That's our lowest fee level. 91% are below 200, and that's what people have typically considered to be poor, although we know it's about 250. And I know there's some talk about changing the way poverty is calculated. If you guys haven't looked into that, look into that. Because the way that started was how much money it cost to buy food, and that has changed dramatically. So our measure of poverty is way off, but nobody's wanted to change it because it would qualify a lot more people for benefits. And then our insurance status: 45% of our patients don't have insurance. Medicaid 32%, Medicare 5%, 18% is commercial and other programs. So that's what our payer mix is. We're anticipating with healthcare reform, our number of uninsured will go down to about 25%. It'll still be a lot. But we'll be getting paid for stuff we're not getting paid for now. We have incredible health resources in this state. The Kansas Health Institute did a county health ranking. Yellow is bad. Southeast Kansas is where I live. So check that out. We've got a 101, a 94, a 100, a 97, an 82, a 99, a 104, a 103, and a 98. So clearly we have a regional problem. And this is based on health outcomes, environment, income, all that kind of stuff. So our rates of diabetes, cancer, you name a chronic disease, we've got it badly. And so that gives you kind of a visual representation of what we're dealing with when we're dealing with our day-to-day stuff. The dental workforce in Southeast Kansas, you guys have probably heard a lot about workforce. This is just a case study in what we're dealing with. There are 44 general practitioners in Southeast Kansas, and not all of them work a full schedule, which I would say is 32 hours a week, for 175,000 residents. So that's about 1 to 4,000. In Kansas, it's about 1 to 3,000. In the country, it's about 1 to 1,200. And it's expected, we've got some really good data on, we have lots of great data in Kansas on all this stuff. But the state ratio is expected to rise to 1 in 3,400 for the state, and 1 in 4,400 in Southeast Kansas, unless I can hire a whole lot of people.